Okay, let's unpack this. Today, we are diving deep into the intricate, high-stakes world of psychotherapeutic drugs. Our source material is a really solid pharmacology chapter. And it's not just lists of drugs. Crucially, it focuses on patient safety, monitoring, all through the lens of the nursing process.
That's right. And our mission today really is to give you that clinical shortcut. We want to synthesize the key drug classes, how they work, and maybe most importantly, the life and death safety risks. These are powerful medications. The goal is for you to walk away understanding the why behind all the careful monitoring needed.
Right. So we're mostly talking about three big categories of mental disorders here. Anxiety, affective disorders like depression, mania, bipolar, and psychoses. And one of the first things the sources highlight is that diagnosis. Well, it's rarely straightforward, is it? Symptoms overlap quite a bit.
Oh, absolutely. And comorbidity is really high, meaning, if you're treating someone for major depression, there's often an underlying anxiety disorder or maybe something else going on too. It gets complex.
So where do we start with treatment? It seems like it all begins with these biochemical theories,
Yeah.
these ideas about what's actually imbalanced in the brain.
Exactly. We often start with the biogenic amine hypothesis. That's the theory that basically a deficiency, a lack of key neurotransmitters, think norepinephrine, dopamine, serotonin, leads to depression. And on the flip side, an excess of them contributes to mania.
All right, deficiency equals depression, excess equals mania. But I remember reading about a more specific idea involving serotonin.
You're thinking of the permissive hypothesis. It's a
Right.
nuance, yeah. It suggests that low serotonin isn't just a factor, it might be the predisposing factor for these affective disorders. So if serotonin levels are down, the whole system is sort of fragile. Whether someone then tips into depression, maybe with low catecholamines, or into mania with high ones, depends on those other amines. Low serotonin sets the stage.
Got it. So these theories kind of give us the roadmap for the drugs, the targets. And what about for psychosis, like schizophrenia? What's the guiding theory there?
That brings us to the dopamine hypothesis. This one links psychotic symptoms, the hallucinations, delusions, to excessive dopamine activity in certain brain pathways. So naturally, the drugs used for psychosis, they're aimed squarely at reducing that dopamine activity, turning down the volume, essentially.
Makes sense. Okay, let's tackle the most common issue first, anxiety. The main players here are the anxiolytic drugs. We're looking at benzodiazepines, alprazolam, diazepam, lorazepam are common ones. And then there's that miscellaneous one, buspirone.
Right. Benzodiazepines or benzos are often first line for acute anxiety. They work fast. Their mechanism is, well, pretty elegant actually. They boost the effect of GABA, that's gamma aminobutyric acid. Think of GABA as the brain's main calming or inhibitory neurotransmitter. So when benzos enhance GABA, they effectively put the brakes on nerve activity. It really depresses the CNS, especially in the limbic system, the emotional centers.
Okay, hits the brakes. But here's where the details really matter for nurses, right? They might all sound similar, those PAM and LAM drugs, but how long they act is very different.
Absolutely critical difference. Alprazolam, like Xanax, is short-acting. Fast relief, but that also means higher potential for dependence, maybe interdose anxiety. Diazepam, Valium, is the longest acting. Its active metabolites stick around for a long time, which can be a problem, especially in older adults or anyone with, say, liver issues. Accumulation risk.
So is there a go-to for older adults if a benzo is needed?
Yes, the sources point this out as a key clinical pearl. Lorazepam, Ativan, is often preferred for older adults. Its metabolism is simpler, less likely to accumulate compared to diazepam.
Good to know. Now, safety. The common side effects are kind of what you'd expect, right? Drowsiness, maybe some confusion, bit of low blood pressure. But what about overdoses? Someone takes too much. Is there a reversal agent?
Well, if it's just benzos, the overdose management is usually supportive care. Keep them safe, monitor breathing. It's rarely fatal on its own. However, and this is a huge however, if they're combined with alcohol, opioids, other CNS depressants, that's when respiratory depression becomes a massive, potentially fatal risk.
Is there an antidote in that scenario?
There is. Flumazenil, it's the antagonist. But, and here's another critical caution, you have to be really careful using it. If the patient has been taking benzos long-term, giving flumazenil can suddenly throw them into acute withdrawal. That can mean seizures, which are obviously very dangerous. So it's not used lightly.
Wow, okay. That's a major consideration.
Yeah.
And speaking of major considerations, buspirone. It's used for anxiety, but it's completely different from the benzos, isn't it?
Totally different category, yeah. Buspirone's mechanism isn't fully pinned down, seems to involve serotonin and maybe some dopamine activity. But the key things for clinicians, it lacks the sedative effects of benzos. Big plus. And it doesn't have that dependency potential.
But it works differently in terms of timing.
Crucially different. It must be taken on a scheduled basis every day. It's not a PRN, take as needed drug like a benzo for panic. Buspirone takes several weeks to build up to its full therapeutic effect. Patients need to understand that.
Okay, good distinction. Let's shift gears to affective disorders. Now we're moving away from GABA and talking about balancing ions, particularly with lithium, the classic mood stabilizer for bipolar disorder, right? Both acute mania and maintenance.
That's the one. Lithium's fascinating. It's just a simple element, an ion, but it seems to alter how sodium ions move across nerve cell membranes, and that affects how catecholamines are metabolized. And that link to sodium, that is the single most critical safety point with lithium.
How so?
Patients absolutely must maintain normal, stable sodium intake and stay well hydrated. If they get dehydrated or their sodium level drops, maybe they have the flu, severe vomiting, diarrhea, or even just start an aggressive low-salt diet, the kidneys try to conserve sodium. And because lithium is handled similarly to sodium.
The kidneys hold on to the lithium too.
Exactly. They reabsorb more lithium and the blood level can spike, potentially reaching toxic levels very quickly.
And that spike is dangerous because lithium has that really narrow therapeutic window, doesn't it?
Extremely narrow. We're talking 1.6 to 1.2 millieql for therapeutic maintenance. There's just not much wiggle room. And the adverse effects track closely with those levels. At the lower end, maybe some mild GI upset, a fine hand tremor. But as it creeps up towards 1.5...
then you see more serious issues.
Yes, you start seeing confusion, drowsiness, worsening tremor. Above 2.0 NEQQL, you're risking seizures. And the big one is cardiac dysrhythmias. Very dangerous.
And other common meds can interfere too.
Oh, yes. Things like thiazide diuretics, often used for blood pressure ACE inhibitors, also for BP, and even common NSAIDs like ibuprofen. They can all reduce lithium clearance and increase the risk of toxicity. Huge interaction potential.
Okay, so intense monitoring is key there. Now let's move to the other side of affective disorders.
Right.
Depression. Antidepressants are first line, but patience is required.
Yeah.
That 4 to 6 week delay before full effect kicks in.
Right, and that delay itself is a major safety factor we need to circle back to.
Definitely. Let's start with the older ones, the first generation.
Yeah.
Tricyclic antidepressants, TCAs like amitriptyline. How do they work?
Their mechanism is basically stopping the recycling of the feel-good neurotransmitters. They block the reuptake of both serotonin and norepinephrine at the synapse. So more of those chemicals are available in the synaptic cleft to transmit signals.
But they come with significant downsides.
Mm-hmm.
Those anticholinergic effects are pretty notorious. Dry mouth, constipation, urinary retention. But the really critical risk is overdose, isn't it?
That's the killer with TCAs, literally. TCA overdose is notoriously lethal, primarily due to cardiotoxicity. It can cause sudden seizures or fatal heart rhythm disturbances. The statistic is stark. Sources estimate 70 to 80% of deaths from TCA overdose happen before the person even gets to the hospital. It's that fast and that severe.
Wow. Okay. If TCAs are risky because of the heart, what about the other first-gen class, the MAOIs, monoamine oxidase inhibitors? They seem even less common now.
They are rarely first line precisely because of their danger profile. They require incredible patient adherence and awareness.
This is the one with the food interactions, right? The hypertensive crisis.
Exactly, that's the big one. MAOIs work by inhibiting the enzyme that breaks down neurotransmitters like norepinephrine, serotonin, and dopamine, but that enzyme also breaks down tyramine, an amino acid found in certain foods.
So if you take an MAOI and eat those foods...
your body can't break down the tyramine. It builds up, triggers a massive release of norepinephrine, and causes a sudden, potentially catastrophic spike in blood pressure, the hypertensive crisis. Severe headache, palpitations, stroke risk. It's an emergency.
What foods are we talking about? People need to know this list.
Absolutely. The classic offenders are aged cheeses, cheddar, Swiss, blue cheese, smoked, pickled, or aged meats, pepperoni, salami, smoked fish, yeast extracts, and certain alcoholic beverages, especially red wines like Chianti.
That requires serious dietary discipline.
It does. And it's not just food. Patients also have to avoid many over-the-counter cold and cough medications, especially decongestants, because they can act as stimulants and trigger the same crisis. Plus, there's the washout period. If you're switching from an MAOI to another antidepressant, especially an SSRI, you need a 2 to 5 week gap where you take neither drug. Otherwise, you risk serotonin syndrome.
Okay, that strictness definitely explains why they aren't used as much.
Yeah.
Which logically brings us to the second-generation antidepressants, SSRIs and SNRIs.
Yeah.
Why the shift? Why are these generally preferred now?
It really was a huge leap forward in terms of safety and tolerability. They have significantly fewer of those troublesome anticholinergic effects compared to TCAs, and critically, much less cardiovascular risk. Overdose is generally much less likely to be fatal.
You know, they work differently.
They're more targeted.
Yeah.
SSRIs, selective serotonin reuptake inhibitors, like fluoxetine, citalopram, sertraline, primarily block the reuptake of just serotonin. SNRIs, serotonin norepinephrine reuptake inhibitors, like venlafaxine, duloxetine, block the reuptake of both serotonin and norepinephrine.
Does that dual action of SNRIs offer any specific advantages?
Sometimes, yes. That norepinephrine component can make SNRIs particularly effective for patients who also have chronic pain conditions like fibromyalgia or neuropathic pain, which often coexist with depression. It can also help with fatigue or lack of energy.
But even though they're safer overall, they aren't without risks. There are still major warnings.
Absolutely. First, there's the FDA black box warning. This is crucial. It mandates close monitoring for worsening depression or the emergence of suicidal thoughts or behaviors. This risk is considered highest, especially in children, adolescents, and young adults during the initial weeks of treatment or when the dosage is changed. That's why that 4-6-week initial period is so critical for observation.
Okay, this suicide risk warning. What else?
We also have to be vigilant for serotonin syndrome. This happens when there's too much serotonin activity in the brain, maybe from taking too high a dose, or combining serotonergic drugs like an SSRI with certain migraine meds or even St. John's wort.
What does serotonin syndrome look like?
It's a collection of symptoms. Think delirium or agitation, tachycardia, fast heart rate, sweating, muscle rigidity, hyperreflexia, overactive reflexes, maybe coarse tremors. It can range from mild to life-threatening, so prompt recognition is key.
And one more really important point for patients starting these meds. You can't just stop them cold turkey, right?
Definitely not. That leads to discontinuation syndrome. It's particularly common with SSRIs that have shorter half-lives, like paroxetine or sertraline. Stopping abruptly can cause flu-like symptoms, aches, fatigue, nausea plus dizziness, irritability, sometimes electric shock-like sensations, brain zaps. It's not dangerous like withdrawal from some drugs, but it feels awful. Needs a slow taper.
So tapering is key. Before we leave antidepressants, can we quickly touch on bipropion? It seems unique.
It is unique. Bupropion, Wellbutrin, acts weakly on dopamine and norepinephrine reuptake, with very little effect on serotonin. This different profile makes it useful for depression, often with fewer sexual side effects than SSRIs. And of course, in its Zyban formulation, it's licensed for smoking cessation, so a versatile drug.
Okay. Let's transition now to the last major category, antipsychotics, used for psychotic disorders like schizophrenia. We have the older ones, the first generation or conventional antipsychotics. Haloperidol is a classic example. How do they work?
These primarily work by blocking dopamine D2 receptors quite strongly, especially in the brain pathways associated with psychosis, like the mesolimbic pathway. And this dopamine blockade is generally quite effective for the positive symptoms of psychosis, the hallucinations, delusions, disorganized thinking.
But less so for other symptoms.
Much less effective, unfortunately, for the negative symptoms, things like apathy, lack of motivation, social withdrawal, flat affect. And sometimes they can even worsen negative symptoms.
And because they block dopamine pretty broadly, they come with those significant movement side effects.
That's the major downside. High risk for extrapyramidal symptoms, or EPS. This umbrella term covers several distinct movement disorders. You can see akathisia, which is this intense inner restlessness, inability to sit still, or acute dystonia, which involves sudden painful muscle spasms, often in the neck or face. Really distressing for patients. Long-term use also risks tardive dyskinesia.
Okay, so the first-gen drugs hit positive symptoms hard but have major motor side effects. That presumably led to the development of the atypical or second-generation antipsychotics like risperidone, olanzapine, clozapine, aripiprazole. What's their advantage?
The key difference is their receptor profile. They still block D2 dopamine receptors, but generally less tightly than the first-gen drugs. And they also strongly block specific serotonin receptors, particularly the 5-HT2A receptor. This dual action modulating both dopamine and serotonin seems to be the key. It allows them to be effective against both positive and negative symptoms.
And the movement side effects.
Significantly lower risk of EPS compared to the first-generation agents. That was a major breakthrough. Patients tolerate them much better in that regard.
But nothing's perfect. The atypicals introduced their own set of serious safety concerns.
They certainly did. One rare but critical risk across the board is neuroleptic malignant syndrome, NMS. It's a medical emergency.
What does NMS look like?
Think extreme muscle rigidity, very high fever, hyperpyrexia, unstable blood pressure, confusion, elevated creatine kinase levels. It can be fatal if not recognized and treated immediately, usually by stopping the drug and providing intensive supportive care.
And then there's clozapine, which has a very specific dangerous side effect.
Right. Clozapine is often remarkably effective, especially for treatment-resistant schizophrenia, but it carries a significant risk of a granulocytosis. That's a potentially fatal drop in white blood cell count, specifically neutrophils, leaving the patient highly vulnerable to infection.
Which requires intense monitoring.
Absolutely mandatory. Weekly blood counts, checking the ANC absolute neutrophil count for the first 6 months of treatment, then less frequently if stable, but monitoring continues for the duration of therapy. It's a huge commitment.
And beyond those acute risks, there's a pervasive long-term issue with atypicals especially.
Yes, the risk of metabolic syndrome. This is a really big deal with long-term use. Many atypical antipsychotics, some more than others, are strongly associated with significant weight gain, increased blood glucose and risk of type 2 diabetes, elevated cholesterol and triglycerides, and sometimes increased blood pressure.
So you trade lower EPS risk for higher metabolic risk.
In many cases, yes. It means patients need regular monitoring of weight, BMI, waist circumference, blood glucose, and lipid profiles. It's a major long-term health concern, increasing cardiovascular risk down the line.
And one more black box warning to mention here.
Yes, similar to antidepressants, antipsychotics carry a black box warning regarding increased risk of death when used to treat behavioral symptoms in older adults with dementia. It's often used off-label for agitation in dementia, but it carries significant risks in that population, often related to cardiovascular events or infections.
Okay, this sheer density of serious risks, NMS, granulocytosis, metabolic syndrome, EPS, suicide risk, it really underscores why the nurse's role is so incredibly vital. Let's synthesize the key nursing process points. Assessment first.
Assessment is absolutely foundational. You need that baseline before starting therapy. Neurologic function, checking for any pre-existing movement issues. Mental status using tools like the Mini Mental State Exam, MMSE, and of course, vital signs.
And the sources really emphasize one specific vital sign measurement that's critical, especially with the older drugs.
Yes, postural blood pressure checks. Taking BP lying down and then immediately upon standing. Orthostatic hypotension, that sudden drop in BP when standing up, is a major fall risk, particularly with TCAs, MAOIs, and even some antipsychotics. A drop of 20 millimeter Hg systolic or 10 millimeter Hg diastolic warrants concern and likely intervention.
And the suicide risk assessment isn't a one-time thing.
Absolutely not. It needs to be ongoing, especially, as we mentioned, during those first 4 to 6 weeks of antidepressant therapy. Remember that paradox, energy might return before mood fully lifts, potentially enabling a suicide attempt. Constant vigilance is needed. Also, practical assessment includes checking for medication adherence. Are they actually swallowing the pills? Especially in patient settings, you have to assess for cheeking or hoarding medication. Check them out.
Okay, assessment is key. What about implementation and patient teaching? What are the absolute must-knows for patients?
The universal rule for all these psychotherapeutics: take them exactly as prescribed. Same time every day helps maintain steady levels. And never stop abruptly. We talked about discontinuation syndrome with SSRIs, SNRIs, but abrupt stopping of antipsychotics can cause withdrawal psychosis. Tapering is almost always necessary.
Specifics for lithium.
Reinforce the need for consistent sodium intake and adequate hydration, usually 2-3 liters of fluid daily unless contraindicated. And they must report any signs of toxicity, immediately worsening tremor, significant GI upset, confusion.
And for MAOIs.
Strict adherence to the tyramine-restricted diet is non-negotiable. They need that list of forbidden foods. And they must be taught to check with a pharmacist or provider before taking any other medication, including over-the-counter cold remedies.
You mentioned something interesting earlier about metabolism varying across populations.
Yes, it's an important point often highlighted in pharmacogenetics. There is significant cultural and genetic variability in how people metabolize drugs. For instance, the sources note that individuals of Asian descent often metabolize certain drugs, like some benzodiazepines and TCAs, more slowly due to variations in liver enzymes, like cytochrome PL450.
Meaning they might need lower doses.
Exactly. They might experience therapeutic effects or, unfortunately, side effects and toxicity at lower doses compared to, say, Caucasian populations. It's a reminder that dosing isn't always one size fits all.
This has been an incredibly dense but vital deep dive. We've hit the 3 main pillars: anxiolytics, the drugs for affective disorders, lithium, TCAs, MAOIs, SSRIs, SNRIs, and the antipsychotics. And throughout, those major safety themes kept coming up. Black box warnings on suicide risk and dementia use, the tyramine crisis with MAOIs, serotonin syndrome, NMS, metabolic issues. It's a lot.
It really is. And maybe the final thought to leave people with, if you connect all these dots, think about the seriousness and sometimes the delayed nature of these risks, NMS showing up weeks later, a granulocytosis requiring months of monitoring, that initial suicide risk window. It really shifts the perspective on the nurse's role, doesn't it? It's far beyond just administering a pill. The nurse becomes the primary safety net, the critical interpreter of subtle changes that might signal a brewing crisis, the first line of defense against these potentially devastating adverse effects. It's arguably some of the highest stakes monitoring in all of pharmacology.
That complexity, that required vigilance.
Yeah.
It really drives home why being this informed is so critical for patient safety. Thank you so much for joining us for this deep dive.